Hello everyone, this is the second part of disorders of sexual development and is the last part. In this video, we are going to see about the remaining 5 topics. So last video I have given the core concepts, and if you have not watched it, kindly watch it. However, I will be repeating these topics as and when required. So first, Androgen Insensitivity Syndrome. பேர்லயே இருக்கு, ஆண்ட்ரோஜன் இருக்கு, ஆனால் அது ஒழுங்காக ஒர்க் ஆகலை. ஆண்ட்ரோஜன் இருந்தும் ஒர்க் ஆகலை அப்படின்னா டெஃபினெட்லி they are going to be karyotypically a male. மேல் அப்படிங்கிறதுனால there is Y chromosome. Y chromosomeல there is SRY gene. SRY gene is going to produce testes. Testesல there are two types of cells. One is Sertoli cells, இன்னொன்று Leydig cells. Sertoli cells வந்து it is going to produce inhibin and also Mullerian inhibiting substance. Mullerian inhibiting substance will inhibit formation of uterus. Next, Leydig cells will produce testosterone. Testosterone will be converted into DHT with the help of 5-alpha reductase, and it will be converted to estradiol by the help of aromatase. GnRH increase ana, the pituitary is going to produce FSH and LH. FSH is going to act on Sertoli cells, whereas LH is going to act on Leydig cells. Negative feedback பொறுத்த வரைக்கும் testosterone is going to have a negative feedback on LH as well as FSH. Ana, inhibin is going to have a negative feedback only on FSH. So coming to androgen insensitivity syndrome. Androgen insensitivity syndrome la rendu type irukku. The first one is complete androgen insensitivity syndrome. Second one is partial androgen insensitivity syndrome. So நம்ம ஆல்ரெடி பார்த்த மாதிரி testosterone is required for conversion into DHT, and DHT is responsible for male-like external genitalia and secondary sexual characters of male. But here in complete AIS, androgen சுத்தமாவே work ஆகல. So what happens to external genitalia and what happens to internal genitalia அப்படின்னு பார்ப்போம். Complete androgen insensitive இருந்துச்சுன்னா there is no action of testosterone, there is no action of DHT. So the patient is going to have an external genitalia which is exactly like female. So there is female-like external genitalia. Ana, in contrast, in partial AIS, there is a minimal testosterone action. In the minimal testosterone is not sufficient enough to produce a male-like genitalia, and also it is not going to produce a exactly female-like genitalia. So it is somewhere in between. So in partial AIS, there is ambiguous genitalia. So what happens to internal genitalia? Complete AISல complete androgen activity இல்லை. Our patient is karyotypically male. So male internal genitalia form ஆகணும் அப்படின்னா testosterone is required. But since there is complete absence, நம்ம என்ன நினைப்போம், there will be formation of female-like internal genitalia அப்படின்னு நினைப்போம். But எங்க twist இருக்கு அப்படின்னா all this pathway is normal, correct? So since Sertoli cells are normally functioning, it is going to produce MIS, which is Mullerian inhibiting substance. So what will this do is, it is going to inhibit formation of the internal genitalia of female also. That is, there is going to be absent uterus. So internal genitalia in complete AIS is going to be absent. In contrast, in partial AIS, there is some amount of testosterone activity. So testis-like structure will be formed. So there is dysgenetic male internal genitalia. So this is the main difference between complete and partial AIS. மற்ற எல்லாமே வந்து it is almost the same. So next, what happens to pubic hair? Remember, in a X karyotype person, pubic hair க்கு the hormone responsible is mainly testosterone, whereas in an XY karyotype individual, pubic hair க்கு the hormone responsible is DHT more than testosterone. So in both these conditions, the pubic hair is going to be scanty. And surprisingly, testosterone is not acting. அதனால there is elevation of testosterone, and this elevated testosterone is converted into estrogen. நம்ம already பார்த்த மாதிரி estrogen is responsible for breast development. So what happens is, the patient with AIS will have a proper breast development. So what happens to hormones? அப்படின்னு பார்த்தோம்னா, the karyotype is male karyotype, and androgenோட functions எதுவுமே நடக்கல அப்படின்னு பாடி சென்ஸ் பண்ணிடுச்சு அப்படின்னா there will be increase in GnRH, and this will in turn will increase the FSH and also LH. So now let's see what happens to the hormone levels. The patient is karyotypically a male. ஒரு மேலுக்கு androgen actions நடக்கல அப்படின்னா what is going to happen? There will be GnRH increase. GnRH increase ஆச்சுன்னா there will be increase in FSH and also increase in LH. LH increase ஆச்சுன்னா there will be elevated testosterone as well. And because of increased FSH, there is increase in inhibin. We know that inhibin is going to have a negative feedback on FSH. So என்ன ஆகும்னா this will in turn decrease the FSH. So net effect will be a normal FSH. So remember, there is increase in GnRH, normal FSH, increased LH and increased testosterone. So குழந்தை பிறந்த உடனே if you look at the external genitalia, it is going to look like a female. So நம்ம என்ன சொல்வோம், this baby is a female. In the baby is going to be grown as a female. At the time of puberty, என்ன நடக்கும் அப்படின்னா this girl is going to come to you with complaints of primary amenorrhea. அப்பதான் நீங்க செக் பண்ணி பார்ப்பீங்க, the patient will have a bilateral inguinal hernia or a mass. இங்க inguinal hernia or mass எதை மீன் பண்ணுதுன்னா there is presence of undescended testis. Why undescended testis? நான் ஆல்ரெடி சொன்ன மாதிரி the inguinal descentக்கு தேவையான ஒரு ஹார்மோன் is testosterone. Testosterone ஆக்ட் ஆகல அப்படின்னா there is going to be arrest of this testis in the inguinal region. That is why there is undescended testis in the inguinal region, and it is going to present as bilateral inguinal mass or inguinal hernia. So இந்த மாதிரி பேஷண்ட்ஸ்க்கு what we can do, investigation வந்து நம்ம வந்து இந்த ஹார்மோன்ஸ் எல்லாத்தையும் பார்க்கலாம், like estrogen, testosterone, FSH, LH இதெல்லாம் பார்க்கலாம். But the investigation of choice remains karyotyping. So this girl is going to come to you with complaints of primary amenorrhea and you are finding some undescended testis. நீங்க இப்போ போயிட்டு அந்த பேஷண்ட் கிட்ட நீங்க கேர்ளே இல்லை நீங்க ஒரு பாய் அப்படின்னு சொன்னாங்கன்னா this is going to be an emotional disaster to the patient, also the relatives, and this must not occur. இது நம்ம நடக்க விடக்கூடாது. So we have to let the girl be a girl, let them be a female. This is going to be the first step. Next step, you have to do gonadectomy. இப்போ undescended testis இருக்கா, இந்த testis நம்ம remove பண்ணணும். Why? This testis is of no use, but this can turn into a tumor later stage. So we have to surgically remove this testis. That is gonadectomy. And we have to give hormone supplementation. What are the hormones used? Regular estrogen, progesterone, ரெண்டு ஹார்மோன் இருக்கு. இதுல எந்த ஹார்மோனை நம்ம யூஸ் பண்ண போறோம் அப்படின்னு பார்ப்போம். Estrogen is required for the female secondary sexual characters, and progesterone is going to protect the uterus. நம்ம complete AISல there is absent internal genitalia, which means there is absent uterus. Uterus இல்லாதவங்களுக்கு நம்ம progesterone கொடுக்கணும்ன்ற அவசியம் இல்லை. So we have to give estrogen only hormone therapy. There is no need for progesterone therapy. So the treatment is going to be let them be a female, gonadectomy and estrogen hormone replacement. In a partial AIS, they will present with ambiguous genitalia. So avangalukku we are going to do vaginoplasty. What is the name of vaginoplasty? It is McIndovaginoplasty or laparoscopic Weichet's vaginoplasty. So this is all you need to know about androgen insensitivity syndrome. So next comes the Sweyers syndrome. Sweyers syndrome la the patient is karyotypically a XY individual. Doubt vanchna, remember Sweyers la or Y irukku, so the patient is an XY karyotype individual. Y chromosome irundhuchna SRY gene act aganum, but the problem lies over here. The SRY gene la there is a point mutation. In the point mutation நடக்கிறதுனால what happens is that the testis is not going to function properly. So sertoli cells form ஆகாது, Leydig cells form ஆகாது, testosterone form ஆகுது, Mullerian inhibiting substance form ஆகுது. So what is happening overall? There is absent androgen activity. The patient is going to have a female like genitalia. So பிறக்கும்போது the patient's sex will be determined as female, and at the time of puberty what happens is that the patient will present you with primary amenorrhea. So what are all the features you're going to find in this patient? Testosterone illa abina, there will be scanty pubic hair. Inge testosterone irundha da it will be converted to estrogen. Testosterone illa abina, there is no estrogen. So there will be absent breast. And third point is MIS is required for inhibiting uterus formation. இங்கே MIS இல்லை அப்படின்னா this is going to cause proper uterus development. So இந்த மாதிரி patient இருந்தாங்கன்னா how are you going to manage? So by birth the patient is female. அதனால we have to let them be female. Regarding the gonads, there will be presence of a dysgenetic testis, and that too it will be undescended testis. So undescended testis means now what we have to do? We have to do gonadectomy. இது மட்டும் இல்லாமல் we have to give a hormone therapy. Estrogen இருக்கு, progesterone இருக்கு. Since this patient is having a proper uterus, we have to protect this uterus from side effects of estrogen like endometrial hyperplasia or cancer. So along with estrogen, we are going to add progesterone. So regarding the course of treatment, first நம்ம estrogen கொடுக்கணும், and after some duration, we will be adding progesterone along with estrogen. So treatment பொறுத்த வரைக்கும் it is let them be females, gonadectomy, and estrogen and progesterone replacement. Vaginoplasty இந்த patient தேவையா? தேவையில்லை. ஏன்னா she is already having a female-like genitals. Vagina is formed normally. So this is about the Sweyers syndrome. Next, Ovotestes. பேருக்கு ஏற்ற மாதிரி ஓவமும் இருக்கு, டெஸ்டிஸ் இருக்கு, ரெண்டுமே இருக்கு. So there are two possibilities. The karyotype can be XX or XY. XX வந்து it's more common. And both of them, regardless of the karyotype, they are going to present you with ambiguous genitalia. Ambiguous genitalia and meaning the external genitalia only. ஸோ அந்த பேபிக்கு ஓவமும் இருக்குது, டெஸ்டிஸும் இருக்குது. ஓவம் என்ன ப்ரொடியூஸ் பண்ணும்? இட் வில் ப்ரொடியூஸ் எஸ்ட்ரோஜன். எஸ்ட்ரோஜன் வில் காஸ் டெவலப்மெண்ட் ஆஃப் breast at puberty. Testis இருக்குது. Testis is responsible for secondary sexual character of males. ஒரு பேஷண்ட் பிறந்த உடனே யூ ஆர் லுக்கிங் அட் தி எக்ஸ்டர்னல் ஜெனிட்டாலியா ஃபார் ஜெண்டர் ஐடென்டிஃபிகேஷன். அது பார்க்க மேல் லைக் இருக்குது. ஸோ யூ ஆர் டிட்டர்மைனிங் த சைல்டு ஆஸ் அ மேல் சைல்டு அப்படின்னு சொல்லி கொடுத்துரும். பட் அட் த டைம் ஆஃப் பியூபர்ட்டி வாட் வில் ஹேப்பன்? தேர் வில் பி breast development and also other secondary sexual characters of male. So about 75% of the patients will have gynecomastia, and since estrogen is also responsible for uterus formation, about 25% will develop uterus and they can also even menstruate. So these are the important points regarding Ovotestes. Next, 5-alpha reductase deficiency. So நம்ம testosterone will be converted to DHT. இந்த ஸ்டெப் நடக்கல அப்படின்னா DHT குறைஞ்சு போயிடும். நம்ம the karyotype is going to be XY only because testosterone ஒழுங்காக ஆக்ட் ஆகல அப்படின்னா it is again in an XY individual. So how the patient is going to present? So patientக்கு testis is present. ஏன்னா Y chromosome இருக்குது, testis is present. Sertoli cells நார்மலாக இருக்கிறதுனால no uterus. Since the DHT is low, there is female external genitalia. So patient வரும்போதே the patient will be a female when she comes to you, and at the puberty she will be presenting with characters of male, that is the secondary sexual characters of male. இந்த மாதிரி வருவாங்க. They may have clitoromegaly, they may have virilization, hirsutism, lowering of voice. இந்த மாதிரி conditions-ஓட the patient will come at the time of puberty. So what are the difference between AIS and 5-alpha reductase அப்படின்னு பார்த்துட்டிங்கன்னா, in AIS there is proper breast development, ஆனால் in 5-alpha reductase deficiency there is no breast. ஸோ இங்கே கேட்கலாம், இந்த டெஸ்டோஸ்டெரான் ஏன் வந்து எஸ்ட்ரோஜனாக மாறி இட் கேன் லீட் டு breast production அப்படி சொல்லி கேட்கலாம். பட் in 5-alpha reductase this is not happening and the reasons are not known. So you have to remember this point. There is no breast development in 5-alpha reductase deficiency. Regarding the internal genitalia, testosterone இருக்குல்ல, if the testosterone is normal, then the internal genitalia is going to be a male internal genitalia. What about pubic hair? Pubic hair is going to be scanty. Pubic hair requirement DHT is important. Next, regarding hormones, remember 5-alpha reductase deficiency will have all hormones normal. Normal testosterone, normal FSH and normal LH. So this is a characteristic of 5-alpha reductase deficiency. In contrast, நம்ம AIS என்ன பார்த்தோம்? There is high testosterone, normal FSH, increased LH. So this is an important table. Next, aromatase deficiency பற்றி சும்மா லைட்டாக பார்ப்போம். What happens? Testosterone will be converted into estrogen by the help of aromatase. Suppose if aromatase is absent, what will happen? There will be accumulation of testosterone, there will be absent estrogen. Testosterone அதிகமாகுது அப்படின்னா in a male child, in a male, no problem. But in a female, there will be ambiguous genitalia. There will be history of hirsutism in mother during pregnancy. So if there is history of hirsutism in mother during pregnancy, the child, if she is a female, then there will be ambiguous genitalia. So these are all the important disorders of sexual development. Hope this was useful and try solving the MCQs. Thank you.